Thanks a lot. Really great to be here. I'm CEO and one of co-founders of the company. My name is Edvardas, and we are building developed actually a teleoperated endovascular robot system, Sentante. The history of endovascular interventions started a long time ago. It was 40 years ago. We used mechanical typewriters back then as a standard technology. And a lot of things have changed since then. So we developed thousands of new endovascular devices. We got computers instead of mechanical typewriters. We went digital since then. But one thing did not change: the way we deliver endovascular treatment to patients. It is the same as it was 40 years ago. So doctor is still standing next to a running X-ray source and manually manipulates guide wires and catheters inserted into the patient. So even though 40 years have passed, we have the same process as we used to have. And endovascular interventions actually expanded, and it's a gold standard treatment for most critical conditions, be it heart attack, stroke, peripheral artery disease, and even some types of cancer. So do doctors do a good job in treating those patients? Absolutely, if they are skilled. But one, we don't have enough skilled doctors, we don't have enough skilled nurses, and the conditions that we provide for doctors and nurses to work are really hazardous. So now we know that X-ray causes radiation, it causes DNA damage to physicians and nurses who are exposed to it every day. It causes cancer and cataracts. They wear lead aprons to protect themselves every day from radiation exposure, and especially for nurses, they have back pains, and you wouldn't meet a nurse who is above age of 50 and would not experience a back pain. The same with physicians, and we still expect them to do a perfect case each time. And it's really hard to show the smell, but I guess this picture illustrates the conditions that physicians are working in. And technology could definitely help here. We have robots out there for precision. We have robots out there for automatization and making processes automatic. We have robots for hazardous work environments and when you cannot physically be there. And we even have robots when you have to do remote work. And even for medical field, just one of those justifications is enough for a robot to exist. So they are built for accuracy, precision, to hold the devices, to position the devices, or to enable remote work. But when we talk about endovascular, we have to check all the boxes. And we have developed a system, Sentante, which checks all the boxes. It is accurate, precise, and for the first time ever allows entire procedure to be performed robotically from a different room. So a physician working from a remote workstation can perform entire procedure using robot, which is inside the cath lab. So Sentante is compatible with standard off-the-shelf endovascular devices and can manipulate 3 devices simultaneously, be it guidewire, catheter, and guide catheter, for example. And this setup allows entire procedure to be performed using robot. We are compatible with guide wires from 014 to 0035 and the catheters 2 to 8 French, so really wide range. And we can use any off-the-shelf devices. So we are device agnostic, but also procedure agnostic. We can do any procedure, be it diagnostic, treatment, you need to place stent, balloon PTA, coiling, anything that is needed can be done using robot. But those are the must-haves. The most important thing is how we do this. So we have developed a revolutionary user interface because the interface is the same guide wire, the same catheter, and the same guide catheter, set of 3 devices that physicians would physically use during the procedure. They have physically them in their hands and manipulate them the way they train to. So you push a guide wire, robot does the same thing inside the patient. You rotate the catheter, exactly the same movement is happening there. But if there's resistance inside the vessel, physician can feel it here real time in his cockpit. So Real-time haptic force feedback provides the same sensation to physician just as if he would work manually next to a patient. And this is robotic digital technology, so we have robotic accuracy, we have extreme precision, we have increased stability, we have possibility to freeze the position of any of the devices. And that's a digital system which enables physician to work better, faster, safer, perform entire procedure using robotic system. So earlier this year, we did quite a lot of preclinical testing of the system. We did very different procedures. We did cadaver procedures, animal study, animal GLP study, 76 procedures in total, very different procedures, be it below the knee, PTA, renal artery stenting, visceral artery PTA. And we have great success. We have 100% technical success rate, 0% safety issues, and no X-ray radiation to any medical personnel. So no one was wearing lead aprons. And what's most important for us is excellent feedback from investigators. Just a couple months ago, we completed our first clinical study. That was a huge achievement for our team. We did 10 patients and 21 procedures, again, very different procedures. Different devices were used, and again, 100% technical success rate, 0% safety issues, no X-ray radiation to any medical personnel. And again, really great feedback from physicians that used the system. And doctors love technology, love this technology. It's super easy to use. It's very easy to learn. We're happy to demonstrate this in Houston. And as a next step, we are bringing this technology to market, but also looking forward to expand indication, not to do only peripheral vascular, but also address neurovascular indication, because the stroke is a #1 cause of disability, severe disability, and the time which we have to treat the stroke or to help that patient is really limited. We have 2-3 golden hours, and if we do procedure in time, the patient is perfectly intact. If we miss this window, the patient stays disabled for the rest of the life. And only less than 30% of eligible patients get treated. The rest of them just don't make to hospital in time. And tele-intervention and robotic system like Sentante with tele-intervention capabilities could dramatically help here and help to solve this issue. So we are basically developing a platform for digital cath lab. At stage 1, we are empowering physician with teleoperated robot system, providing robotic accuracy, precision, stability, and safety. We provide non-sterile X-ray free workplace for physicians who can work in very different way now. They are all of a sudden not sterile, but have desktop interface. And all this will create conditions to provide the procedure better, faster, and safer. But as a next step, we really are looking forward for inter-hospital tele-interventions to increase access to care to those stroke patients, emergent stroke patients, thereby reducing costs of care and with the satellite hospital setup. But this haptic force feedback, which we have in our system, is not just a nice feature for a physician. It is data. It is data of actual forces used with actual devices during the procedure. And when we pair it with X-ray imaging data, we have a full data, basically a blueprint, digital blueprint of entire procedure. And we can slice this data in very different directions. We can use this data for procedure optimization. We can create simulated vascular models for really realistic training platform with the system. But also we can use this data to train AI and increase autonomy of the robot. So in the future, the robot would be able to do procedures better, faster, and safer on its own, and to help physicians even more. So this is all what we do and why. And we have the robot here in Houston Methodist. Happy to show the video footage of it installed and over to Thomas in the cath lab.
Okay. Thomas, how you doing? Can you hear us okay?
Yeah, I can hear you perfectly. So, good afternoon to everyone, and thanks, Alan, for your kind invitation. It is our huge privilege and pleasure to come to this super high-tech facility. And we would like to demonstrate this robot. So we have this morning just installed it in one of your cath labs, and this is Sentante, actually. So it is a remote cockpit. So one part of the robot was just filmed, and probably you can see from the cath lab as a separate thing. And there you can see the user interface. So the user interface is 3 devices. So it is a typical guide wire. It is 2 catheters, and it is super intuitive to use them. Again, you have some information about the devices on both of these screens, and the manipulation is straightforward. Typically, it takes less than 5 minutes for the doctor to start using. There is a security pedal. I press it, and once it is pressed, I can actually move back and forth any of the devices. And if you can see in the screen, so these devices, I can rotate, I can push, I can pull, I can do all the things. But it's not only about the movement of one or the devices. It's actually about the interface. It's not joystick. It's not a gamepad. It's actually the devices. And there is a haptic feedback. So if I push the guide wire up to the wall, I can feel the resistance. And this is extremely nice feature. So nowadays, only 2 robots in the market, so DaVinci 5 and Sentante, has haptic force feedback. So if you push the wire, and the wire has a resistance in the patient, you can feel it in the cockpit. And if you take a Lunderquist wire, so you feel resistance, but it's pretty safe. If you take a CTO wire, so you have to be extremely careful, but you feel that haptics in your fingers. And you can do actually all the tricks you know, and you have learned through your career, so you can use whatever, you can rotate, you can twist, you can tackle the plaque. So everything is allowed there. The other feature is once I release these devices, so they will recenter in this cockpit, but they would not move on the patient side. So now I'm releasing, and you see they actually moving here, but they are not moving on the patient side. So all in all, this nice cockpit actually is acting as the joysticks, and they should not be changed very often. We recommend to do it once per week, and despite thin or thick wire, whatever platform, balloon stents, microcatheters, coils could be used in the patient side. These remain the same. It is just a little bit calibrated to have a different tactile feedback in the cockpit, but otherwise it is acting like a joystick. So it is not time consuming to be changed every time. So the next thing is actually I can do the procedure without my gloves. So I can add there an additional device. It's digital inflator. I can add another device, and I heard some talks about 3D fusion images fusion. So actually the doctor can work in the nice workstation and work with another third-party software, and it's enabling technology. So you are not dependent on nurse just to make fusion. You can do a lot of things yourself. So, and what Edvardas has mentioned just now, it is digitalization. So it's not about only, okay, I can move a catheter, I can move a wire or whatever. It is actually about converting this procedure from analog to digital. So for instance, I am happy with the position of the wire. I am happy with the position of the guiding catheter. So I can lock guiding catheter, I can lock a guide wire, and without any possibility to lose the position of guide wire. I'm just removing with one hand. I am not securing neither guide wire nor guiding catheter, and actually it is removed. What it means? It means you don't need to ask a nurse, could you hold my guiding catheter while I'm removing the balloon? So it is a very nice feature of time saving and workforce saving. The other feature of digitalization is actually ability to use a precision mode. So once you press a precision mode, you have to move, let's say, 1 millimeter on the patient side. So you will have to move on the cockpit 5 millimeters. So now when precision mode is on, I'm actually moving a guide wire quite a lot in this side, but on the patient side, it moves just extremely slowly, just a little bit. So if you need an extreme precision, it is a nice feature and you can have it. Another feature for digitalization is measuring the length. So for instance, I would like to measure the length from this to this point. So I do have the numbers of each catheter. So I don't need any measuring device anymore. I can say it's okay, 44 centimeters. I subtract it up to this position and it's 45.8. It means the lesion is 1.8 centimeters. So these features actually is converting the procedure from manual analog to digital. But in addition to that, as Edvardas mentioned, we are creating a platform. So a platform of converting the whole cath lab, the digital one. So first of all, it's eliminating a black box. So it's integrating of various devices. And there's one feature I could show you, balloon inflator. So let's say I am creating some atmospheres up to 6. And we see here a nice graph of atmospheres over time. And it is a digital record, actually. And if you need to inflate a balloon for your clinical trial or for your patient, up to 6 atmospheres for 3 minutes, not always it is so. Sometimes the atmospheres drops, and actually you have to have it adjusted. So in addition to that, we do have this feature as a possibility to move it to your digital electronic patient health records. So these are the previous inflations, and they could be just scanned with your mobile phone or with the iPad, and they could be moved. This graph could be moved to the electronic health record system. So this is about converting the cath lab to a digital one, and we do believe it is the future. So I don't know, do we have any other questions from the audience?
Yeah, thank you for that, Tomas. And I know you guys had a video. Do you want to show that as well before we go to questions?
Let's.
Yeah, so this video was taken just half an hour ago.
And again, special thanks to the video production team for doing this last minute request. Great job, guys.
Thank you so much. So actually here you can see how the device moves in a vascular model. The same, it actually acts whether it is a preclinical trial, so animal, or in clinical trials with a human. So actually you can see moving hands. They are sterile, single-use hands, and they are changed for each patient, for each procedure. And you can mount any device out of the shelf over the wire catheters. So be it a balloon stand, microcatheter, any type of guiding catheters up to 8 French, any platform for the guide wires, so 014, 018, 035, anything could be used in this robotic system. And actually, I think this is pretty much the movie, just to show the concept, just what is behind me in the next room. So I'm sitting in a very safe environment, no lead aprons, and I can actually manipulate these devices remotely. It's kind of an extension of my hands, but it's not only about the doctor, it's also about the nurse. So actually, no nurse has to step in while X-rays are on. And it's a dramatic change. So no one has to wear lead aprons. And for the future, it is a stepping back stones for us to do remote procedures. As it is for the first time ever, the first robot which can perform the whole procedure robotically. Up till now, no other endovascular robot could perform the whole procedure with zero X-ray exposure to all medical personnel.
Wonderful. Listen, thanks, Tomas. I think we're just going to cut that live feed to you to go on to the next thing. Thank you very much for patching in there. We've got quite a few questions coming in for our audience. I believe the first one was, how does Sentante compare to Corinda's CorePath? That's a good one, I guess.
That's an excellent question. And as Thomas mentioned, we designed Sentante to be able to do entire procedure robotically. So meaning we cannot do the arterial access, but from the moment when introducer sheath is placed inside the patient, you connect a robot to it and you can do entire procedure robotically. While you obviously know you had a Corinda system installed in here, with Corindas you have to start the procedure manually using the over-the-wire devices, advance guide catheter to the position you want to, then, only then, you connect the robot to a patient, go to shielded cockpit, use joysticks to advance those those devices to needed position, but then you come back again, disconnect the robot, and complete procedure manually. So, yes, it saves some X-ray exposure to physicians, but the workflow is so much more complicated. Corindas was designed for coronary interventions, so they are compatible with rapid exchange devices and specific devices, 014 guidewire and rapid exchange stand, so catheter-based devices. While we have developed a system which is device agnostic, you can use a wide range of devices, you can use different devices, do different procedures, and use very intuitive and natural way to advance to manipulate the endovascular devices. And this is also additional, a big difference. Sentante is working with over-the-wire devices. So this is now developed for peripheral vascular interventions, but very soon we'll expand indication, move to neurovascular as well to help those stroke patients. And also the haptic feedback. It is a feature which is very much appreciated by physicians, and it's a digital data that our system generates. So basically we had to build a big hardware to become a software company. But on the other hand, this leaves the decision to physicians. So if physician feeling what's happening needs to push hard, it can, or he or she can push hard that guide wire. If you have a floppy 014 guide wire, you need to be very gentle, you can be very gentle. So robot does not take away those decisions. While in Corinda's case, the robot doesn't have haptic force feedback. You do not measure the forces, so the robot has to have some force set to advance those catheters. Like any force, like your X newtons, for example, you set for advancement of that catheter. And in one situation, that might be a perfect setup, but what if the situation changes? What if you use different device? So you have basically to validate your system to many different situations and many different devices, while Sentante is developed as a platform technology to be device agnostic, to be procedure agnostic, and we can easily adopt the technology to use different devices and perform different procedures. So that is probably the biggest differences from Corinda's system.
Thanks for that. And I guess we can probably combine two questions here. So, has this been used in the clinic yet, or is it preclinical? And can you maybe comment on the EU robotic device approval process? How is all that linking together?
So we are not FDA approved device. We are not CE marked device in Europe yet. We're going there. So just a couple of months ago, we completed our clinical trial, collected first clinical data with the system, and we are moving towards submission for regulatory approval in Europe. But we also are planning our clinical trial here in the US to collect clinical data and submit for FDA approval next year.
And how does that kind of work then? So, with the FDA approval, is it possible to do like some stuff simultaneously, so you can take some data sets from the EU, apply them to the FDA strategy, or is it really like you're starting fresh?
We have had a couple pre-submission meetings with FDA, discussed our preclinical and clinical validation strategy, and the EU data will be submitted together with the US data. But obviously, FDA wants to see the US-based data in the US facility, so they can be sure that this device is safe to use and can work well in the US cath lab.
Wonderful. And I think we have another final question there. So is it possible now or one day to program an A and B and have the wires automatically go to pre-selected points? Very specific. Yeah.
That is an excellent question, and it is not possible today, but as I mentioned, we collect the data of the procedure. That's a digital record of entire procedure, so we can definitely train the system using this data later on to do certain things automatically. For example, one simple example is retraction of devices after the procedure. So the robot knows what forces were used to go inside. So it is easy to develop a solution that robot would automatically retract the devices after the procedure in a safe manner, because it has data, it knows how to function. So this is a very simple example, but going next step forward, yes, we can use this data to also to manipulate the devices in different ways. And when we collect a sufficient data set of real clinical data, of real clinical use cases of the system, we'll use this to develop next steps. And one of those absolutely can be increased autonomy of the system and ability to advance, not only retract devices to a needed position.
Okay, so I don't know if our viewers can see this, but we actually have Dr. Lumsden now over in Mighty. Can we patch this? This is kind of, maybe not pull the audio in, because I'm not sure what they're saying. But yeah, we go. So we actually have Dr. Lumsden right now over in Mighty at the Bookout Center, and he is getting some hands-on experience for this system. So again, just to keep in mind to our viewers, like Sentante have come all the way over from Lithuania. Okay, so I do really appreciate the effort that you put in here. And they've been here since Saturday, and I know they managed to go down to Johnson Space Center, so another unique kind of selling point for Houston, right at the doorsteps for NASA. And it's really experiences like this where, by coming on site, getting to know people face to face, and actually having hands-on experience, you just can't replicate that virtually. So again, kudos for you to coming all the way, and we really do appreciate it.
Thanks a lot, Stuart, for inviting us, for having us here. It's really a big privilege for us to be here and to demo the system to you.